Professor, can you hear my voice?
Yes, we can.
Okay. Professor, welcome to our online conference. Now, let's welcome Mr. Hu Penhong from Nitingfang General Hospital, Singapore, to give the presentation. His topic is current studies of endoscopic fusion, uniportal and biportal endoscopic spinal surgery. Welcome.
你听到我说话吗？我是胡鹏宏医生。
我可以听到。
好，大家好，我是胡鹏宏医生，我是顾问医生，国立大学医学主治黄廷芳综合医院。我会用英文解说。Today my topic is current status of endoscopic fusion, uniportal and biportal endoscopic spine surgery. Thank you for Jiaxing Station and Bones, as well as ISUBE for inviting me to give this talk. It's my great honor. I'm part of Untitled General Hospital. We take care of about 12% of Singapore population. And in 2020, about 60% of my cases are done as an endoscopic spine surgery. And in 2021, we move up to about 80% of the cases. I do a mixture of uniportal and biportal surgery, ranging from stenosis to fusion and discectomy. These are my mentors. I thank them for all the effort they put in to train me. And we talk about today the indications for fusion first. So Simmons and all and Blumenthal came out with landmark papers to describe when do we fuse the spine. So we look at the patient's factor, some dynamic radiograph, and we make decision based on MRI facet orientation, whether there's presence of facet effusion, and whether there is any restabilization signs, as well as the disc height. We also decide whether the patient is stable, potentially unstable, or unstable. Generally, as we are endoscopic surgeon, if the patient is potentially unstable, I think these days with much ability to, yes, I think 有人 raise hands 吗？你们听得到我讲话对吗？
我们可以听到。
Okay, someone is raising the hand. Okay, anyway, so I think with endoscopic surgery and particularly biportal surgeries, literature has shown that we can preserve the facet joint very well. So sometimes potentially unstable patient, we can actually consider decompression. But not largely in the unstable patient where they present with severe back pain, instability pain, coupled with high disc and kyphotic angle with a change in translation or dynamic film, with a large joint effusion, they are the candidates for fusion. Generally, based on these two papers that we look at in the two tables, my conclusion from these two papers is that suggested that if you have high disc height, lack of restabilization signs such as osteophyte or collapsed disc space, and with more than 50% facet orientation, as well as significant translation and angulation in the flexion extension film, they are suggestion of fusion will benefit the patients. Based on my own clinical judgment as well, if the patient has significant back pain getting up from the chair or from the bed, or where there is a change in position, with or without claudication, there is a sign that the person with a spondylolisthesis may benefit from fusion. Of course, there are patients who have undergone multiple revision and they have less than 50% of the facet joints. These patients may benefit from fusion as well. Now that we know that the fusion is for spondylolisthesis, just to be sure, I generally guideline recommend that for pure axial back pain without mechanical back pain, fusion is not recommended. Just to note that fusion is just one of the options. Recently, I published a paper in the Molecular Spine, International Journal of Molecular Science, it's Science Journal, and they discussed the various way of managing degenerative disc disease. We came up with this table that has a mnemonic of 5 R's, and you can see that rigid fusion is actually the last stage of treatment. After that, we have decided that we need to fuse the patient. There are three aspects that we think of. First, we need to prepare the fusion bed. And fusion bed has either posterolateral fusion from the facet joint or the transverse process, or interbody fusion. And then we put in biologics, and of course, we stabilize the spine so that fusion can take place. Today's topic is on endoscopic fusion, so largely it's on interbody fusion and talking about how to prepare the end plate. To prepare the end plate well, we need to visualize well, and we need to have a good preparation to prevent cartilage, to prevent end plate damage and subsequent subsidence. And of course, subsequently, we put in a good fusion device and good pedicle screws, or cortical trajectory screw, whichever screw that you are comfortable, to prevent the person from immobilize the spine joints for fusion to take place. What is the advantage of interbody fusion is a concept of load sharing. Interbody fusion, especially in a large disc space, provide anterior support to the spinal column. And as a result, there is a less tendency for the pedicle screw and rod breakage. And that has highlighted very well in a mechanical study published in Spine in 2000. And then the next question is, should we do minimally invasive or open? I think in this pandemic situation, when we have to cancel elective surgery, preservation of beds in the hospital is key to the administrator's mind, as well as doctors and patients' mind. Even relatives of the patient do not want their relative to be in hospital for a prolonged period. So we feel that minimally invasive is no longer just a good to do, but something that we should do. We have published that in the, as James invites comments, you can read about that. So now we go into types of endoscopic fusion in the uniportal and biportal. Of course, there are other open or tubular methods, but it's beyond the scope of today's talk. In uniportal fusion, in the current literature, the more popular ones is either, we call it K-leaf, Cambin's triangle approach, with a facet preservation without interlaminar decompression, using indirect decompression and put in a cage through the Cambin's triangle. Or we can do a full facet sacrificing lumbar interbody, transforaminal lumbar interbody fusion, we call it ET-leaf. And there are endoscopic assisted cases in O-leaf fusion. But bear in mind, do not confuse about that. It is an O-leaf surgery. The endoscopic part is just to remove herniated disc or fragments that is that has moved into the spinal canal. In biportal, we tend to have U-leaf, which is basically UBE, lumbar interbody fusion. There's people who call it B-leaf, and also XT-leaf, which is extreme lateral lumbar interbody fusion, which put in larger cages. We have published this picture. You can find it online, and there are various routes to this fusion method that I've described. Generally, more popular one in uniportal is actually K-leaf. Part of the reason is that this K-leaf has been there for the past 10 years, but it is not without its problem, which I will describe later. ET-leaf, which is the traditional route which is shared with biportal surgery, is not so common in the literature, but we are publishing new articles on this. Generally, to consider fusion strategy, whether to approach from the front to the back, there are many considerations. Just to highlight a few, in the MRI, we don't just diagnose whether there's spondylolisthesis. We need to look at whether the front corridor allows for O-leaf to take place, whether the aorta is too close to the psoas, or whether the psoas is too high up that we cannot do an extreme lateral and lumbar interbody fusion. In this patient, for example, I think the OC corridor is too narrow, and for X-leaf is also not suitable. So we go from the back. When we go from the back, then we have to analyze whether there's bony or soft tissue compression, and also whether the transforaminal window is suitable for K-leaf. These are multiple considerations. And of course, we are coming out with studies that it seems that endoscopic fusion preserves the fat and muscle layers in the paraspinal muscles. I'll be probably publishing about that at the later part of this year. This is a video showing a recent patient that I see in the clinic. This patient doesn't need fusion. However, just to highlight, if there is like two nerve roots in the same foramen, you have to consider very much more consideration have to be thought of before you decide to do a K-leaf. In fact, I think it's contraindicated. You may cause exiting nerve root injury. So what are the tools for fusion? In uniportal, it's complicated. In K-leaf, you can use a transforaminal scope, which is 30 degrees, or interlaminar scope, which is 15 degrees. Interlaminar scope will be difficult in a patient who are larger in size. For ET leaf, which is posterolateral part of the fusion, you can use the various stenosis scope. We tend to use the larger delta scope if we need it for ET leaf because they have a 13 mm diameter as a working retractor or working cannula. Biportal, however, provide flexibility and allow us to be in one position using our non-dominant hand to hold the scope and right dominant hand, as well as engaging our assistant in the fusion. So it's efficient. You can do it with one type of scope. You can do it with a 0 or 30 degree scope as well. You can put in huge cages, which is currently limited in uniportal surgery. I have discussed this in the literature on the differences between the uniportal and biportal, also in the previous station, so I won't go into that. You can read up on these two articles that we wrote up about the differences. Just to summarize, the handling is different. In uniportal, we tend to need to rotate our body frequently as well as our hand frequently because there's only one hole that we can see. And the scope is at the angle of 15 to 30 degrees. In biportal surgery, however, we can comfortably hold the scope and then use our dominant hand to do the work and be in the single position standing most of the time. And if you look at your shoulders or ask your assistant to look at your shoulder position, you realize that you tend to abduct your shoulder more in uniportal surgery, and hence there's a possibility of rotator cuff tendinitis. While in biportal, you tend to keep your hands down in a very nice working position. Furthermore, you can engage your assistant in helping retraction in biportal surgery or even doing osteotomy. However, in uniportal, there's only one skin incision. You have to do all by yourself. So just to share some technical pearls, I do limited number of K-leaf. My camp of surgery tends to believe in ET leaf or biportal fusion. However, I work with Professor Sario on this paper, and these are the pictures. Basically, we get into, we open up the facet joint slightly, but usually if the Campbell's triangle is sufficient dimension, we will get in the working retractor and subsequently perform discectomy. The discectomy is done in stages. We can drill the disc, or you can use a specialized curette, as you can see in these pictures. If you drill, each of the drill is about 3.5 mm. If you drill a depth of 4 of that, you have a 12 mm. If you drill a depth of about 4 of the drill sides, you get 16 mm. And by that, it's probably sufficient to put in an expandable cage. And you can use some specialized curette as well to prepare the end plate. So that reminds us that there is limited space, and the cage size as well as the dimension and width is limited in K-leaf. In uniportal fusion, there are two approaches. We are currently submitting a paper to discuss that. Just to suffice to say, there's a facet approach and there's a pass approach. The papers that we have published so far discuss more on the pass approach, but the outside-in facet approach is appropriate as well. The docking is on different, but you can see that it's pretty similar to our scope portal in biportal surgery. These are just some of the intra-op picture that I've taken recently. So we dock on the spinal laminar junction, just like the biportal surgery. And then we drill on the pars as well as the facet joint. And then we introduce the working cannula onto the disc and prepare the disc and insert the interbody cage through the working cannula. This is, you can see from here in this picture that the facet joint is completely removed. This is just a schematic diagram of how it's performed. It is largely similar to biportal surgery. So essentially, we need to use the working cannula as well as the scope in a collinear fashion to retract the nerve root and insert the cage in the uniportal posterolateral fusion. This is just the results of the surgery. The cage-wise, we can't put as big a cage as X T-leaf, but we can put in traditional T-leaf cages. This is a video of a case done recently on a 57-year-old man who have a pain score of 8 in the back and the leg with a spondylolisthesis in L4-5, with a reasonable disc height, with no restabilization sign. We need to perform endoscopic fusion after consent. And this is how we did it. These are the pictures that you have seen just now. We are standing on the left side. We first expose the spinal laminar junction. We use the equipment that can be provided by bones as well. And then we drill the facet joint. We can do the basically resection of the inferior articular facet. Of course, we can't use the osteotome too much. I've tried using the uniportal osteotome. They are really small and very inefficient. One of the osteotome nearly break inside the patient, so I tend to just drill them. As a result of just pure drilling, you tend to have less kind of a bone harvest because most of them are gone as bone dust. So we retrieve the inferior articular facet joint now, and then we can do the SAP resection after we put the scope and rotate it sideways. So just to speed up a bit, we cover the disc, protect the nerve roots, and then we prepare the disc. The disc preparation is very similar in terms of biportal, uniportal. However, all are placed through the working channel, so you can't get an assistant to retract for you. Also, we have to use mostly the drill and the probe rather than using curettes. There's no really good curette in the market for uniportal fusion. Nevertheless, we managed to put in the nice interbody cage. It's a PEEK material. You can use titanium cage as well. And then we explore the nerve roots and then make sure that everything seems okay. You can go to the contralateral side and decompress. And then finally, you put in the cages and the screw. I sent this patient home the next day. I did not put a drain. Sorry, I continue sharing my screen.
Yes.
Okay, so
the connector have the problem right now.
Yeah, so you saw my video just now, right? So let's continue. So this is published in the International Disciplinary Neurosurgery, and the technique is described. So we talk about biportal first, and then the biportal, we will be talking about it in an article published next year. For me, the biportal incision is as such. On the left side, I tend to focus on the working portal. The working portal should be close to the disc so that we can insert the cage in a more collinear fashion. And then we plan about 3 cm away from the working portal for our viewing portal. So on the right side, it tends to be a bit lower because I want to get the working ports to be closer to the disc space. Otherwise, in XT leaf, we need a separate incision, or you have to place both the viewing portal and the working portal further away from the pedicle. This is some intraoperative picture that we have done recently. Just of note, I tend to put in the initial phase, I would put the spinal needle on the opposite side so that we can get oriented, but that's not necessary if you are experienced. And then this is a case that we've done recently. I hope the video works this time better without me being kicked out. So a 69-year-old man who presented with for a significant foraminal stenosis and low-grade scoliosis of about 20 degrees. It's a one-side lateral recess as well as foraminal stenosis. We put in the portals. We perform a facetectomy, prepare for the fusion. Of course, we have to expose. I tend to dock in the spinal laminar junction as well, which is quite similar to my uniportal strategy. We can also dock directly on the facet joint. You can use the cutting board to start off and then expose the interlaminar space. I tend to expose the interlaminar space clearly before I perform osteotomy. That is more of an inside-out kind of technique. So we curate out all the superficial flavum. You can see the deep layer now very clearly. And then after that, you can see the quite a medialized as a superior articular process. So then we perform an osteotomy. Biportal is very efficient in getting rid of the facet joint. In the uniportal fusion, unless you are very familiar with drilling, it will take some time while you are drilling the facet joint of the inferior articular facet. However, of course, with practice, you can do that as well in efficient fashion. But I think Biportal is good in harvesting bone in that way. You can use the osteotome very efficiently. And then you expose the deeper layer. You can get to you can see the superficial, the deep layer of the ligamentum flavum. This is the midpoint of the caudal lamina. And then we can curate out the flavum of the ipsilateral side. Mind you, the other side, this patient doesn't have a contralateral foraminal stenosis nor central stenosis. So we focus on just performing the fusion. We expose the disc space using a Sorry. Yeah, I don't know why today's video is not that good. Okay, anyway, we're about to just basically we put in the cage after that. This time round, we put in a pretty large cage. You can put in, if you are more lateral and more space, we can actually put in an XT leaf as well. You check the nerve root, they are pretty good. And then you can use
Professor.
Yeah.
Can you show your PPT?
Oh.
We can't see the PPT.
You can't? Okay, we can share again. Can you see now?
Yes.
Okay, so how much of the biportal fusion did you see? You managed to see some of it? 可以看得到我刚才的那个双管道融合手术吗？
刚才的应该没看到，没看到。
哦，那我重新播一次吧。你们有时间吗 ？OK，
我们可以的。
OK， 所以我基本so 基本上this patient have foraminal stenosis on the right side, so we performing right biportal fusion. 现在你看得到我的 video 哈？看得到吗？
可以看到。
Okay. So just like uniportal surgery, I dock on the spinal laminar junction. I tend to still do the interlaminar decompression first before I do the facetectomy. We will later on write an article that describe you can do from the outside in as well, but that's beyond the scope of today's talk. So I will basically prepare the facet joint after we do the expose the deep layer of ligamentum flavum. I would like to see the superior articular process medial aspect of it before I perform an osteotomy with my osteotome. So now I think biportal surgery is superior in terms of harvesting bone because you do not need to drill too much for the harvesting of the inferior articular facet. In uniportal, I tend to drill the facet off. Hence, I have limited bone graft. So now we can see that we are removing the inferior articular facet, and then subsequently we'll be removing the superior articular facet. So now with the deep layer of the flavum exposed, we also go on to remove the ligamentum flavum. We can go contralaterally, of course. I think several experts have shown you earlier in today's talk. For this patient, doesn't have a contralateral stenosis, so I'm just doing ipsilateral side. We clear off the peridiscal epidural bleeding, epidural capillary vessels, and then we put in the cage with preparing the disc in a standard fashion. Subsequently, we put in a relatively larger interbody cage compared to my uniportal method. You can do as big a cage as O-leaf cages if you have Okay. So anyway, okay, I move to the next slide. I think they 可以看得到吗？ I move to the next slide.
可以看到。
Yeah, I think 可能今天那个video 比较长，所以每次都被踢出去。所以basically biportal and uniportal endoscopic fusion has been gaining lots of research activities now. We have also published our series on the uniportal fusion, both in the grade 2 spondylolisthesis, severe collapsed disc space, like the case I've shown you in the biportal fusion, as well as in the scoliosis, degenerative scoliosis. But in degenerative scoliosis, we tend to do them with patients who are less than 30 degrees of the curve. If you do multiple level fusion, they do well as well in using endoscopic fusion. And my mentor, Prof. Hao Donghua, as well as his team, you can see a familiar name like Dr. Song and Dr. Yum and Chowen Park as well, has published a series in the minimally invasive also versus endoscopic, and endoscopic does better in terms of the early post-op pain. So in the meta-analysis, you can see that from the paper, there's very limited literature on the posterior lateral fusion in the uniportal surgery. In fact, I wrote one of the first few papers on this. However, there are more literature coming out from our camp. Basically, biportal fusion is well established and they do well in terms of early pain score, post-op, length of stay, as well as currently also having papers to show that they have good fusion. K-leaf is very well established, it's been there for 10 years. They have advantage of being able to be done under local anesthesia and sedation. However, there is a questionable exiting nerve root injury rate as well as subsidence rate because they tend to use smaller footprint cages compared to our posterior lateral fusion by uniportal or even larger cages in biportal. For O-leaf, I think some people get the idea that we can perform O-leaf through the scope. I need to correct this. O-leaf is performed as O-leaf. Okay, the scope is used if there's a herniated disc or if there is a stenosis caused by OPLL or some sort that come from the anterior compartment, and you do not want to go to the back to do decompression. So you use O-leaf assisted scope, as in this case, you can see from my next slide that you can remove the ruptured disc from the front. And anyway, these are done by a small number of surgeons who are familiar with both O-leaf as well as endoscopy, uniportal endoscopy. The most common indication, but a bit expensive, is to do O-leaf from the front and then the scope to decompress at the back. So for that, maybe if there's such an extensive surgery, why not do XT-leaf when you do a biportal scope and you can put a large cage from the back? That's what my own personal opinions are. Anyway, these are the differences between K-leaf and ET-leaf. The approach is different. One has a larger area to work with in the ET-leaf. The size of scope is bigger. You can put in a larger cage, but you have to do facetectomy. And because you have to do facetectomy, you cannot do it under LA sedation. But because you are doing facetectomy, you can go contralateral side as well and do a direct decompression. ET-leaf is similar to biportal. So all the advantage of ET-leaf is also demonstrated in biportal fusion. I wrote this up. I think biportal fusion, uniportal fusion, etc. They are actually at the quaternary ladder. So, or at least a tertiary ladder. We need to be familiar with the decompression and discectomy before we engage fusion surgery. So overall, in my personal training myself and other surgeons, I find that uniportal posterior lateral fusion is really hard to train people. I think the technical difficulty is quite significant. Some of my colleagues, not colleagues, some of the people I've seen perform surgery for the whole day. For UBE fusion, however, the learning curve may be a little bit more reasonable. However, with both type of surgery, they provide good outcome if you experience in handling the technique. In conclusion, it's like Shaolin versus Wudang. There is no really a better way or a best way of doing the same thing. One hole is good, two holes can be better if you are familiar with it. If not, if you are familiar with one hole is equally good. The learning curve, however, I find that Biportal Fusion is very steep, and hence you can see that the ET-Leaf number of literature is very limited, and both techniques require long-term evaluation. I'm done with my talk. I'm sorry that I was knocked out a few times in the Zoom meeting. I hope you all enjoy my talk. Any question, please let me know. Thank you.
Thank you for your speech. It's very wonderful. Because of the time, let's go straight to the next presentation. Thank you.
Thank you.